Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even fewer are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Good afternoon, and welcome to VITALS, brought to you by Northeast Ohio Medical University in collaboration with University Hospitals of Cleveland. My name is Dr. John Langell, and I'm pleased to bring you VITALS, Value, Innovation, Technology, and Service, the tools that today's transformational leaders are using to improve healthcare. Today, I'm excited to introduce Dr. Rishi Singh. He is the Vice President and Chief Medical Officer of Cleveland Clinic Martin North and Cleveland Clinic South Hospitals in Florida. Dr. Singh is a staff surgeon at Cleveland Clinic, Florida, professor of ophthalmology at the Lerner College of Medicine, and principal research investigator for the Center for Ophthalmic Bioinformatics. He serves on the Cleveland Clinic Board of Governors, while he also maintains an active clinical practice. Dr. Singh has authored more than 200 peer-reviewed publications, books, and book chapters, and serves as the principal investigator of numerous national clinical trials advancing the treatment of retinal disease. Please join me in welcoming Dr. Singh.
Thank you for that introduction. It's a pleasure to be here on VITALS. Really, I've watched many of these programs myself in the past, and it's awe-inspiring to be in the realm of the people considered for this program. So I really appreciate the invitation. And I'm going to today provide you a background on myself. I'll discuss the current state of healthcare within the U.S. market and talk about where the opportunities are, where physicians can be best suited to lead these efforts and really be involved in all aspects of leading healthcare and leading the change of healthcare and what we have to encounter in the future. So just for background, who am I? I was born in upstate New York, moved to Nashua, New Hampshire for most of my high school years. I was educated in Boston, went to Boston University for undergrad and graduate school, went to Mass Eye and Ear for residency at Harvard for ophthalmology, and came out to Cleveland, Ohio, which I thought was going to be a 2-year plan. Ended up being 18 years later. My wife and I were looking at each other saying, I guess this is where we're settling. And we've continued on in our careers here. My wife is Assistant Dean of Clerkships at Case Western Reserve University Medical School. And she's also the Cleveland VA system and very in charge of education there, and has a very good career in 2 physician families. Always hard to find balances when you have 2 physicians. We found that Cleveland was the best place for both of us to work together for many, many years. And my son is a proud sophomore at Ohio State. Very proud after this year's tournament win. So obviously that hopefully will continue in the next couple of years. But he's been a wonderful student there and has actually decided to go from finance to pre-med, which I don't know what that means yet, but we'll have to keep in touch with that and let you know what happens to him over time. So I thought I'd talk about myself and how I became interested in hospital administration. And if you asked me 15, 20 years ago, what would I be doing? I don't think I could tell you what I'd be doing right now is what it would be. I've had a lot of experience in clinical care, teaching, and research. I was a lead of some of the early operations issues at the Cole Eye Institute in Cleveland, Ohio, where we had a lot of providers join us. Over almost 400 FTEs are part of that system, 96 providers and 26 offices. I am well known in the field of my specialty, which is retinal surgery and medical treatments of retinal diseases, for research, for education, and also for clinical care. And I received multiple funding sources from both institutional and government or agencies. I've led over 17 national clinical trials. I have over 300 publications, research publications in various fields. And one of the keys to my success over time has really been involving things that are on the bleeding edge of technology. And you're going to hear that theme a little bit more today about how the technology advances that we are seeing have to be embraced by physicians, and we have to be part of the solution. And I was actually the person who developed the Epic applications for my field on ophthalmology, but also for consents and for kiosk entry into our system at Cleveland Clinic. I've led a large research team for many years. This has been out of my interest at educating medical students, residents, fellows, and the program has just grown. This is our lab meeting last year with multiple of our principal investigators present, but also the medical students. It's so awe-inspiring and gratifying to see medical students go through 4 years and then eventually match into my field. And this year was not unlike many years we have. We had 9 of our students graduate, go on to great ophthalmology residencies. We had 22 research presentations at major medical meetings and 29 peer-reviewed publications. So really fantastic to contribute to the field. This is one, again, thing where I think that we have really tried to work together as a team. And truly, it's been a team effort to lead this and to get to where we are from that standpoint. So how did I get involved in hospital administration? And you might, say an ophthalmologist, what would they know about putting patients in a hospital or bedding patients or admitting patients or so on and so forth? The answer is that we can be involved in various ways. In my way, it was because I looked at ophthalmology as being an entry point. We had a lot of expertise in various levels, buy and bill medicine, ambulatory surgery, running high efficiency clinics, being able to see a lot of people, having still high patient experience scores. And so how can we leverage that expertise in the wider hospital arena? And so part of the work that I was doing was part of the Board of Governors, where we are a physician-led organization at Cleveland Clinic. We serve with our physician population as leaders for our group and the Board of Governors, and we provide them annual professional reviews, but also give advice to the Chief of Staff's office, as well as the CEO, Tom Mahalovic, on where the gaps are in our organization and what we can do better for our physician populations. But I've also led a lot of other hospital-based initiatives, which were very, I think, primitive and early in my stages of developing that enterprise-wide leadership, focusing on coding and documentation. Now, many of you might say, well, we don't have a class on coding and documentation. We never had one in medical school. How are we supposed to know it? And the answer is you should know it. We should be able to help you and educate you on all of those benefits in coding and documentation and what can occur in your offices and how we can help you do it quicker, easier, with less involvement from you. And that has been the way I have involved myself. And then I'll touch on that a little bit later in the talk about technology and how we can use technology to help with the coding and documentation initiative. So it takes that off of your plate in order to do that. And I've also served on a variety of different other committees. Probably the more interesting one to me has been this Innovations and Conflict of Interest Committee, where we look at our innovative doctors, some of our most interesting researchers, and try to manage the conflict of both conducting a clinical trial, being part of a spinoff company, and obviously managing the arm's length analysis that will come out of such an important clinical trial that will lead to hopefully clinical benefit for the patient. So let's talk about the challenges in healthcare right now. And you're probably well aware of this, but maybe if you aren't, this will be kind of a summary and give you a sense of what's happening in the healthcare market right now. We've seen rising costs and declining margins for hospitals. It started really around the COVID pandemic. We saw wages go through the roof in regards to nursing. We saw a very finicky physician population that was willing to move to other locations and leave legacy practices. There was a lot of pent-up time during the COVID pandemic where the physicians didn't leave necessarily, they were huddling in place. And then once COVID was over, they all decided to go different places. The ability to have allegiance to a single healthcare institution is really quite rare nowadays. It used to be back in my generation that most people had 4 jobs before they find their final job. Now it's closer to 11 jobs for even physician populations. So we're seeing a finickiness to the healthcare market, especially with nurses, PAs, physicians in regards to where they might go in that area. We're also seeing that there's an increased demand on services with limited resources. We know that our baby boomer generation is getting older now. That's still continuing to get older. We're seeing that population flux come into our hospitals. And especially in rural hospitals, this can be really impacted because we're seeing that rural hospitals are vulnerable to closure. And this is a recent study that was done in 2024 that looked at all of those hospitals that are vulnerable to closure due to a negative margin right now. And you can see that some approach even 40% of hospitals in the US market where they're vulnerable to closure. We also have physician burnout and workforce shortages, and we'll touch on that a little bit more later in the talk, but workforce shortages are real. When I first got to my hospital in Florida, where I am the vice president and chief medical officer, I was encountered with a nursing workforce of 300 travelers and a total workforce of 1,200 nurses. So one out of every four nurses was a traveler. And that was because we had severe workforce shortages in the remaining nurses we had. And so we had to bring in agency nursing as part of that. I'm proud to say that we're now down to less than 20 nurses that are traveling in a workforce of almost 1,400 nurses now. But that was after a lot of effort, recruitment at the nursing school level, scholarship deliveries, things like that were helpful as well. And also creating touch points with them as they got into our system. We still have a need for more technical nursing. That's definitely a need and area, and certainly that will continue over time. So we will try to work toward reducing that even further. And I think a lot of us are struggling with the value-based care models. If you're familiar with Medicare Advantage programs, those are really driving capitated environments. Cost of care is considered as part of that. Outcomes are considered part of that. This is all new to healthcare markets. In the past, it used to be a volume-based solution. The more volume you did, the more you were paid for things. And I think as adequately as many healthcare insurance companies are wising up to it, it's not only volume, but it's also value. And that does make sense to a lot of us. I'm sure many of you have seen this as well. And I think that it does lead to a healthier outcome for patients if we can provide both volume and value to them over time. Physician burnout has continued and it's real. And I think we saw this early on with primary care, and now we're seeing it really across the board. When we look at our primary care doctors, we know that there's a severe lack of primary care physicians. Physicians are graduating with more debt than ever before. During the COVID pandemic, many of the people that would have potentially gotten scholarships or gotten financial support from their parents didn't occur because of all of the slowdown in the economy. And many of them are going into more debt than ever before. And it's astronomically high. It can be averaging anywhere from $400,000 to $500,000 in debt when they do graduate. And therefore, they're picking specialties which are high paying specialties. And a lot of the issues that you see on the bottom of the contributions to physician burnout are the things that we all face as physicians. And even as an ophthalmologist, I face this a lot. There's a lot of time spent on charting and paperwork. There's a lot of hours that are spent at work beyond the patient care and clinical side of things. Our computerization sounded really great at the beginning. And I have to say, this is, again, one of the call to arms and why I was involved at the grassroots level with our EMR system, is that when a physician is involved in designing that system, it could lead to a less laborious outcome for the doctor involved or the nurse involved or the clinical people involved. When it's not, it's just handed to you, you can imagine the workflows may not be adequate. You may have to redo a lot of the workflows to get them to what we do normally in clinical practice, and therefore the efficiencies aren't seen. So again, one of the areas that we could all participate in, but we didn't. When the Affordable Care Act and the areas that were rolled out, which required EMR systems to occur, we weren't part of those discussions. There were large companies, Cerna, Epic, others that were doing this. And it really took ourselves as physicians, and especially the Cleveland Clinic, where we have a very good relationship with Epic, to be involved at the grassroots level and to develop the system needed to be efficient clinical practice. So where is some of this financial instability coming from? It's coming from policy-driven reimbursement cuts. We're seeing a lot of changes within both Medicare and Medicaid across the board. Many of our Medicare patients are higher than ever before in the population. And if you know enough about Medicare, you can understand that for every Medicare hospitalization, the hospital actually loses 7% for every hospitalization that's there. We know that the costs of healthcare haven't kept up with the reimbursements. If you look at the lower right graph, you see in fields like behavioral health, nephrology, burns and wounds, pulmonary, infectious disease, that the level of cost is higher than the reimbursement for those specialties in those areas. And we know that our labor markets are a big part of our driving cost of healthcare. As I mentioned to you, the inflationary costs of people has occurred in past years, and rightly so. I think some of the aspects were underpaid, but some of them are also, again, as I said, very finicky. Physicians and clinicians, and even down to the level of technicians, will leave if if there's $2 or $3 more on the table these days. The allegiance of organizations like the Cleveland Clinic, like University Hospital, are pretty much over. I have to say that that's been a major transition for a lot of us, and so many people are willing to leave. The cultural change is quite significant for those individuals. And we know that as we talked about, infrastructure and maintenance costs are rising. Many of our buildings across hospitals are very old, and the requirements to keep them up to date are quite expensive. We always talk about it like the medical tax. When you replace a door in a medical facility, it feels like it's almost 3x of what you do to replace that door in your own home because of all of the requirements that are there. Whenever you label something medical, the costs certainly rise in the result of that. And we see that medical service lines are shrinking. When you look at things like obstetrics, chemotherapy, oncology, they're all shrinking in nature. And emergency services and surgical services are being trimmed to do the more profitable things, especially at the for-profit entities like HCA and Tenet, where they don't have to be community-based hospitals like we have at the Cleveland Clinic. They can leave gaps of care on the table, especially in urban centers or in rural areas, and then they can focus on the things that produce profitability for them. Here's just a quick graph to show you the rural obstetrical care dilemma that's occurring, where there's really obstetrical deserts that are occurring. And I can tell you this from my perspective, we actually had to close one of our obstetrical units in our hospital in Florida and consolidate it to a single hospital. We were running 2 OB systems and we consolidated to one. And that was after a lot of discussion, which really focused not on the cost around the system, but it was really about recruiting physicians to the Florida market for obstetrical care. It's become a very litigious area, especially for obstetrical care across the United States. The individuals that are even in the state of Florida, many of them don't carry malpractice because malpractice means that the malpractice insurance will pay out automatically. So they don't even take malpractice insurance necessarily. And the hospitals themselves are finding it difficult to staff individuals due to some of the more recent abortion laws that are occurring in states as well that are very, very restrictive. And so that's been areas where obstetrics have been affected, but the other areas have been affected as well. And so we're seeing a shrinking of these medical services as a result of a lot of these issues. And we're growing our healthcare deserts, as I talked about. As I said to you before, the rural hospitals are at risk, and we're seeing that many of our healthcare professional shortages are occurring in rural locations. This shows you a graph of sort of those areas and where they are. This is causing rising patient costs and travel distances for emergency and routine care. Even veterans are being affected. And most recently, there have been some really major cuts in veteran care, which we hope will continue, but it's almost 70,000 individuals that they're planning on laying off from the VA system. So we need increased reliance, unfortunately, on urgent care, which are sometimes expensive models, and telemedicine, which is imperfect to stop these gaps. Okay, so now I presented you the gloom and doom. So let's talk about the optimism. How can you, as individuals listening to this program today, be part of the solution? Because we need you. Realistically, we don't have enough physician leaders in organizations. We need them for both their clinical expertise as well as their business acumen. Traditional physician leadership lacks sometimes operational experience, but yet now we're having more physicians than ever participate in the operation side of the work to understand how process flow works from beginning of the patient checking in to the end of the patient checking out and all the things in between. And we cannot simply rely on administrators. Administrators are great people. My best friends are administrators. My closest mentor in Ohio was an administrator, but they struggle to understand the patient-centeredness of care sometimes. They struggle to understand the process flow of care. Many of the best administrators are those who roll up their sleeves and put on scrubs and come to clinic and come to the OR and spend time with you. But there's not enough of them out there. And certainly we need more physicians to play a larger role. This is a very complex reimbursement model that we're creating. I mentioned to you the value-based model. And in order for us to understand that, we need clinicians to then cater and determine what are the right recipes for various disease states to treat. So for example, in chemotherapy, if a drug is not approved by an insurance company, how do we develop the best process of care and the chemotherapy agents we need to pick for that patient to help us meet the guidelines of the insurance company and have the best outcome and not to assume more cost because we were trying to choose an agent that was not on their formulary. We need physicians to help with this. And we need forward-thinking leaders who can balance efficiency and quality in these many ways. So we need solutions to our healthcare challenges. And let me kind of talk about some of those ways physicians are really adept and the most equipped to do this. We are mentors. We work with our students, our fellows, our residents. We're able to coach and support peers in our practices, our nurses, our front desk staff. We've done a lot of this work before, so we are incredibly adept at being part of the solution. And we develop diverse teams with various skill sets in our ORs and our clinics to make sure that we have all facets of our care model addressed. We can balance teaching, clinical duties, and research. And you may think of this as a three-legged stool, and many of us focus on the clinical duties, but the teaching and the research can be just as potentially lucrative and also noteworthy to bring more patients to your practice, as well as the teaching for future pipeline development and growth is very, very important to continue. And again, this strong mentorship culture that we've been able to create as physicians with trainees and so on and so forth can lead to better staff retention and engagement over time. We're, as physicians, very well versed at running high volume outpatient facilities. We're really efficient at managing 50 plus patients a day. We have expertise in coordinating between multiple specialties, diagnostic services. We know when a patient should be referred and when they could be kept. And so some of that expertise does not fall on administrators. And so they need to understand kind of how we balance the scheduling demands with still providing high quality care and reducing all of those aspects that may ding us in regards to value-based care. And again, it's about maximizing productivity without compromising care for our patients over time. We have expertise in ambulatory surgery centers. Many of our physicians are co-owners in these centers. They understand patient turnover is important. They understand that leadership in maintaining compliance and maintaining accreditation and safety standards when you're the owner of the facility is very, very important. They understand cost containment and supply chain management. So they understand what to do to lower their the cost of care to improve their margins and eventually to improve the financials to keep our doors open for more patients who can't necessarily always afford our care. And we can navigate the buy and bill healthcare economics. And for those who may not be familiar with this term, many of our physicians buy and bill medical medications, infusionary care. In eye care, we have injections, which are chemotherapy drugs. Rheumatologists do the same thing. Buy and bill medicine is a very common model for reimbursement. It provides a slight financial upside to the physician practice, but we have to be very, very good of claims, coding, and billing regulations, be upfront and know all those really, really well. Otherwise, you may be holding the bill for a $6,000 infusion when the insurance company denies it. So we're able to do all that and really work with payers and vendors and leverage economies of scale for purchasing and contracting. So we're really well equipped at working together as teams. And one of the additional pieces, I'll say that physicians are, in general, very emotionally intelligent and patient individuals. We know how to take struggles, complications in the operating room. We know how to deliver bad news to patients. We have to communicate sometimes very complex diagnoses to families. And we have to manage difficult conversations around things like in my area, vision loss and treatment options, but also the welfare changes that may occur and the impact to the social determinants of health that may occur as a result of being in those situations. So we're well aware of that. And finally, we're tech savvy and adaptable. I think one of the things that we've actually seen is that if you look at the way that the physicians have been going through their evolution the past few years, we've embraced electronic record. There is almost no physician I know at this point that's not an electronic record. If you are, I would love to meet you sometimes, but most, if not all of us, are using EMR to a significant degree. We've become more savvy about using it. And I think a lot of the physicians have actually started to become involved in designing them, improving them, and developing them over time. So one of the things that also makes physicians good administrators and good leaders is crisis management, because we are resilient and we manage unexpected complications daily, and we have the ability to adapt to regulatory and policy environments. And during the pandemic, we had the biggest challenge of all in crisis management, right? We all spent the pandemic taking care of patients, developing new protocols, implementing new strategies, but all of it worked to some extent. We were able to keep more people alive with less staff, and that's really resilience. And I think, again, that speaks volumes to how we as physicians can be leaders. So let's focus for the future of healthcare. What can we all do to improve the future of healthcare? And I'm going to actually give you some solutions that we're actually working on and using right now at the Cleveland Clinic in Florida to show you what we're doing. We can lead our hospitals into these new payment models for care delivery. We can develop the pathways, the care paths, the ability to develop catchment systems for those following off of these care delivery models. Those can all be very, very physician-led, and they are very physician-led and nursing-led for the most part. We can champion interdisciplinary collaboration between departments. That's a huge one. First of all, patient experience scores are really around the collaboration of care. When they see a team work together, a nurse with a doctor, with a consultant, with a additional PT/OT provider, that leads to enhanced outcomes and enhanced patient experience scores for those people that are receiving that care, because they see the collaboration between departments. And physicians can be the catalyst for that, because they can be like-minded and work together in developing that. And because they create patient-centered policies, they should be able to enhance outcome and efficiency. So how are we looking at this from all those things? And I know AI is a big field, and we always talk about AI, and I'm sure many of you have used things like ChatGPT, but I'm going to give you concrete examples of where we've been able to do this, both with patients, with caregivers, and with our organization. And why were you doing this to leverage it? Because I talked about all the challenges of healthcare, but let's try to take them on a very granular level and focus on each one. So in regards to patients, our patients want to be heard. They want to spend more time with us. They want to feel like we're not typing or we're spending time looking at a computer. We want to spend more time with them in person. With caregivers and with individuals, we want to set expectations in regards to what their day is going to be like. Are we going to have 7 add-ons today? Are we going to have the ability to keep you later than normal so you can't make it to your son or daughter's extracurricular activity? With artificial intelligence, we can predict now what the actual volumes will be per day and then staff appropriately with that. And we're using these systems right now in place. These are not pipe dreams. These are actually occurring right now in our system and really improving our caregiver experience and what we're able to do. And how about from an organizational perspective? What are we doing? Well, we can use a lot of the metrics to forecast volumes, determine gaps, figure out why patients aren't being discharged from our hospital on a daily basis by looking at their individual case and determining from there what the delays might be, whether it's imaging, whether it's because they didn't get a line placed, because they had a need for a discharge plan, which hasn't been performed yet. Those are things we're all able to do. And we've done all these things now. We've actually worked with a company called Palantir, and amongst many, many others that I can talk about today, that have really been helpful at advancing healthcare and addressing some of these challenges we all are facing. Let me give you some examples of that, and this is the virtual scribes example. And I've used this in practice now for the past 6 months. I've been very impressed with this. It's going to be, I think, the future of healthcare. It's only going to get better. But what this is essentially is it is a app that listens to your conversation, and you can have additional people in the room, and it'll recognize who's speaking and who's talking, and it will transcribe your entirety of your conversation. And truly, this is using natural language processing and artificial intelligence essentially to create that natural narrative that you would have of the patient in an orderly fashion so that you don't spend your time charting afterward. I can tell you that the fidelity of this is over 90% in my hands. And I'm not an expert user by any stretch of the imagination, but it certainly has improved the patient face time and the ability to spend more time talking to the patient and therefore addressing their concerns rather than looking at a computer. And we're rolling this out across the entire clinic system. In the next 3 to 6 months, it'll be complete, but it's going to be a great add-on to our physicians. But think about this more deeply. Think about where we could use this for nursing and the time spent with nursing. How much time does a nurse spend with the patient actually delivering care, and how much do they spend time with charting their care? In addition to the PTOT individuals who spend time, how much time are they spending in the actual physical therapy, rehabbing a patient versus actually talking to them? This has huge impacts in both the inpatient, ED, and outpatient setting for patients. We've also advanced technology for things like hospital care at home. We can provide hospital level care in the comfort of your home in Florida. In our 3 hospital system, we've been able to do that. We bed about 20 to 25 patients a day, and we deliver the unit to your home. It has cellular connection, has a iPad with the ability with a call bell to address a nurse who is waiting for you immediately. We have paramedics that come into your home, deliver you medication, can also have wound care specialists and home health aides come out to you as well as phlebotomy or lab services come out to you. So these networks occur right now, and we're able to do all of this within your comfort of your home. What impact has this had? We've actually bedded since the beginning about 1,300 patients, avoided 4,000 brick and mortar days. We have an average daily census around 15 to 20 patients. We've had over 30,000 in-home encounters. Our readmission rates are some of the best we've ever seen in the industry. Around 9.6% of patients are readmitted within 30 days. About 1.5% of patients are escalated back to the hospital within 12 hours, a very low mortality rate. And we're writing publications about this, but the patient experience scores have really been off the charts. They don't complain about the food because it's their own. They don't complain about the bed because it's their own, but they certainly love the experience being with their families and loved ones when they're recovering from that. So I'm going to leave you with the last couple of slides here and my final thoughts, but how do you get involved? I've given you a lot of different things to think about here. And maybe you're sitting there in the audience and listening to this and saying, boy, those all sound great, but those might not be available at my hospital. And these are just some of the multiple areas you can be involved with, both in joining a hospital committee, participating in peer review, engaging in strategic planning. We're always looking for people to work with us on what strategies we should employ to grow our business, grow our volume, touch more lives with patients. Those are all things we hope to do with individuals and physicians and individuals who are like-minded in those ways. But there's lots of different things in policy and governance, both at the state level and the national level, that can be helpful. And certainly we have the need for everyone to be involved, because we have obviously limited resources in regards to who the administrators may be. Having more physicians involved can be very, very valuable at developing that care path and that care journey together. So I just want to finish with some final thoughts, and I'm really looking forward to the question and answer period of this section. But hospitals need physician leadership roles for their unique skills. And we have the unique ability to really balance patient care, innovation, and business in a patient-centric fashion. And I think that's really unmatched. If you look at other individuals who might come to our facility or administrators, we are truly unique and can really reset the conversation. And you want to be part of it. You are the consumer of these outcomes. And so it's best for you to be involved as much as possible. And again, we definitely need strong leaders from all specialties of medicine, no matter which specialty you consider, to really transform care within the United States in the near-term future. So thank you for that. Really appreciate the time and happy to take questions.
Thank you, Doctor, for a very interesting speech that you provided and for agreeing to take some questions. We're heading into the Q&A portion now, and my name is Cheryl Powell. I am the executive editor of the Akron Beacon Journal. Before moving into editing, I was actually a reporter and medical writer for about 15 years. So this is an area that's really of interest to me. And I found out from your speech, we do have something in common. I also have a son who is, he's a junior and he is pre-med as well.
Oh,
so
great.
he's also following that path. He just took the dreaded MCAT. So I did not see him at all during Christmas break because he was just locked up in his room studying. But thank you again for taking some questions. I did want to start off. You talked a lot about the importance of having physician leaders. So, what are some of the skills that a physician needs to become a good leader, and what are some tips for developing those skills? You personally mentioned having a mentor, so I'm assuming that that is part of developing that skill.
Yeah. So I think some of the essential skills are things I mentioned a little bit during the talk, but other ones to add to that would be obviously being an emotionally intelligent leader is very, very important. I think that some of the toughest conversations you'll have is trying to tell people a situation in which they might not like the outcome. And there can be some very tense moments, emotionally, from the physician or the other providers in the room, from the situation I discussed about, obstetrics and gynecology, trying to consolidate care. There's some really high emotions that lead into that. And so I think trying to really have that strong emotional intelligence background is very, very important in order to negotiate that. I think strong negotiating skills are very important. Those can be taught as well. I mean, you don't have to be, you can be a horrible negotiator like I am with my wife at home, but I'm much better at work. She gets 90% of the vote. I get 10% at home, but at work you can develop a consensus to get to yes. And sometimes some of the best negotiations can be where both parties feel like they have had some concessions on both sides of it. And so there's that value that I think is great to have in an individual like that. And the last piece I would say is organizational skills. And I think this has become, Cheryl, if I had to say, I think this is one that has become far easier to accomplish nowadays. With all the different things that we have available to us, we can be far more organized than ever before. So just as an example, I had 3 meetings this morning. And in the 3 meetings this morning, they were back to back. It was every half an hour. And I could have said, boy, I have like a list of things to do and I didn't write anything down. But I recorded the conversation, which is part of our team's application. I'm able to transcribe it and use artificial intelligence to produce me a things to do list. I send it out to the group. I address my things to do, and they have theirs. And so we've entered a very, very different market now, which I think is great to see. And I think that those are some of the major qualities I would say are very valuable to us, really being good physician leaders.
Right. Obviously, you're in a key leadership position with the Cleveland Clinic within your role. In that role, what are some of the key challenges and also the opportunities that you're facing?
Yeah, so I think the challenges are the ones that we were talking about here. The cost of care is rising exponentially. And the other side of the coin is reimbursement rates are being ratcheted down. And I don't think that healthcare organizations, the insurance companies understand what is really transpiring on the grassroots level. For them, it's a profit loss statement. For us, it's day-to-day operations and activities which we're facing. When you have people come to you and tell you, I could be paid $5,000, $10,000 more to be at a place like Taco Bell, actually, than in healthcare, we have problems. And that's what occurs sometimes. With all of the shortages we've had, there've been a lot of different transitions there, and that's been difficult for people to manage. The other challenge I would say to you is simply access. I think one of the challenges we're facing is that with the larger population growth that we're having, and in Florida, as you know, there's been a huge influx of people. 5% are 65 plus in our counties are coming to our area. So 5% growth in that 65 plus category is pretty big for us to handle. And that leads to then issues with the phone systems and getting into us. It leads to the number of providers that are there. How do we recruit doctors to us? We're trying to attract doctors, but every healthcare place is trying to attract doctors. How do we differentiate ourselves in that market space? Those have been some of the topics we've had to work on, but we've been very successful at it. Thankfully, in my tenure there, we've recruited over 45 doctors in the past 3 years of my time there, which has been a great thing for us. We've doubled the number of doctors, tripled the number of advanced practice providers in the past 5 years. So going back a little bit further. So really added value to our system, which has been great to see. But it's a challenge for all healthcare organizations.
Yeah, definitely. You mentioned you're serving a lot of different needs in your role. I mean, you have to balance the needs of patients, medical staff, support staff, and the health of the organization as a whole. So how do you balance all those different, sometimes conflicting needs?
Yeah, it's a tough one because I think I've always said this in the kindest way possible. Physicians make sometimes some bad business decisions for the good of patients because and for people for that matter. I think it cannot be a black and white scenario. I think a lot of times we're kind of put into a situation where it is simply has to be profitability, or at least break even budgets is what we're trying to achieve in many ways.
Mm-hmm.
The problem with that is that it loses the people involved, and you have to be very cautious of the discussions that happen too. I'll give you a quick example. We were discussing something recently about a retirement of an individual in a service that we provide in the hospital, and we felt that we could absorb that volume and other providers in that area. We don't need to really rehire another individual. And the response I got from the department was, "Oh, well, you're closing our department in the next 3 to 5 years." And that was simply not the case. I just don't think it's the right time to hire. So it takes a lot of hand-holding, a lot of talking, a lot of discussion, a lot of meeting. While virtual meetings are good, I still think there's a huge value add to in-person meetings. We do a lot of in-person meetings still. I think we'll go back to a lot of in-person meetings as time goes on too, just to connect to people. I mean, I think body language and, you can really read people when you're in a room together, how uncomfortable it can be or how difficult conversations can be. But through Teams and through other things, it's really hard to have those kind of in-person conversations.
For sure. Sure. I also wanted to ask some questions related to your field of expertise in ophthalmology. What are some of the most pressing unmet clinical needs you're seeing in that field today?
Yeah, we have big challenges. In ophthalmology, in particular, in my field, one of the biggest challenges we have is dosing regimens and getting people keeping their sight. We're able to give them drugs that improve their sight, but the problem is all the long-term data looks really not great for us. And so we need more durable drugs that are going to last longer for those patients and those individuals. The other thing we need to have is more providers. We have a lack of providers in our field in general, in our specialty, and we need to look at models to expand our care and whether we need to see these patients as often as we're seeing them. So there's an opportunity there to, I think, expand the care that we're receiving, that we're giving to patients in that area. And ophthalmology in general has been a really high quality specialty, high welfare delivery specialty, which has been great. I think it still has its challenges in regards to how much we can deliver and how much we can improve people. I think we've hit a bar that we have not surpassed yet as far as our outcomes go.
All right. So looking back, what advice would you give to your younger self, as a medical student interested in the field of ophthalmology?
Yeah, so I think there are a couple, Cheryl, and you touched on one of them before, which we didn't get to talk about, but just mentorship. I don't think that anyone needs per se formal mentorship, but you can have various mentors who will keep evolving over time, and they just need to be somebody you can touch base with either socially or in a comfortable scenario. It doesn't have to be formalized. I need to meet with you once a month on Zoom and spend time with you. It can be as informal as saying, "Hey, would you mind if I reached out to you if I have questions or concerns, or would you want to grab dinner or a drink and talk about something, or coffee and talk about something that I'd like your advice on, like your thoughts on?" That is, I think having more mentorship is something that anyone can value. And certainly, I think a lot of us, when we're younger, think we can do this all on our own. And what I've learned if anything, is that the more people you have, the more cooks you have in the kitchen, you still can do much better off actually than if you didn't have had fewer. So I think that was a realization that occurs to many of us over time, and certainly I wasn't immune from that. I have great people I tap on now, and I have people that tap on me. So it's really been a really nice two-way street. I think the other thing I might tell myself is that enjoy the journey, because of the fact that I think that there is so much going on in regards to healthcare innovation, delivery models, all these things. Don't think of yourself in the way that you need to specifically do one specific thing. It may sound good or valuable, but just go with the flow, be adaptable, learn where the market's headed, and decide if that's something you want to continue with or change gears. I think there's a lot of opportunity for even physicians to go on and leave practice, go on to industry, go on to reviewing things for others in pharmaceutical companies, or working with innovation in pharmaceutical companies, or even with the big bad insurance companies. I'm just kidding. Physicians can be part of the solution on that side of things.
Sure.
So there can be a value add in having those individuals work in insurance companies and develop the next policies for healthcare delivery. So I think there's a lot of opportunity there to help individuals develop that, and I'm truly excited by the future of what healthcare has in store.
Great. I think we have time for one more question. You spoke at the very beginning talking about, on a personal level, finding balance. And so what advice would you give to medical students regarding their career planning and trying to find that balance between professional and personal lives?
Yeah. So there's not one particular career I could tell you has an amazing personal life these days. I think all of them have their challenges. I think it's about setting boundaries and goals for yourself, right? So there have been individuals who have said, you know what, family and leisure means a lot to me, and therefore I'm only going to be 4 days a week. And that's okay. I think that's a personally reasonable thing. I think setting those expectations on the front end of your jobs when you do come to your careers is also very important. It sounds, I think as most physicians are, we're pleasers. We want to obviously please individuals and make them feel like, that we can do everything for them. The problem with that is that we also hurt ourselves in that process. And I think that setting some really realistic boundaries for yourself and trying to understand how you can please others, but also please yourself is very, very important in that. And I think that the other piece to this is that there needs to be continued focus on your own health and wellness. Don't skip your normal maintenance examinations, things like that. I actually do every year on my birthday. I take it off, and I take it off for a reason, because I go to the doctor's office. So I know that every year on my birthday sounds really boring, but as I get older and older, I realize it's a super valuable thing to recheck yourself and to get yourself in the right healthcare that you should be receiving as an individual, because you have to take care of yourself in order to take care of others. So.
Right. Want to be a good example as a patient, yeah. Right?
Absolutely.
Thank you, Doctor, very much for your time and for sharing today.
Thank you, Cheryl.
Thank you, Dr. Singh. And thank you to all who have joined us today. Next month's speaker for Vitals is Dr. Ted Technos, President and Scientific Director for the University Hospital's Seidman Cancer Center.
This is Vitals, Visionary Health Leadership in Action.